A case of a 32-year-old male with persistent asthma, chronic rhinosinusitis and nasal polyposis. A 32-year-old male was referred to the ENT department of hospital with complaints of persistent headache, facial pain, nasal congestion, sneezing, rhinorrhea with anterior and posterior discharge, cough, and difficulty in nasal breathing. The past medical history of the patient revealed that he suffered persistent nasal symptoms since the age of 20 years, and an additional diagnosis of bronchial asthma was made 4 years prior to his current presentation. However, there was no history of any other chronic illness, like diabetes or hypertension, or any allergy. The family history of the patient was significant for asthma and diabetes in his mother. In the past, he occasionally visited his physician for relief of nasal symptoms, but was non-compliant in taking prescribed medicines, resulting in non-satisfactory relief. For asthma, he had been prescribed a metered-dose inhaler containing bdsnide 160 microgram plus formoterol 4.5 microgram that he was taking irregularly about once or twice in every 2 to 3 days, besides taking theophylline 200 mg, along with oral montelukast 10 mg once daily in the evenings. At current presentation, he was well oriented, but in distress due to bothersome nasal-oral symptoms. Chest X-ray and a bedside ECG showed no significant findings. Seeing his bothersome nasal symptoms, an anterior rhinoscopy examination was performed, which revealed presence of pale, gray polypoid masses arising through middle meatus and prolapsing into the nasal cavity. A CT scan of the patient's head showed an appearance of sinonasal polyposis with polypoid soft tissue masses within the paranasal sinuses. Additional observation revealed opacification of paranasal sinuses with polyps in nasal cavity, and a deviation of the nasal septum. The patient was reluctant to have any surgical intervention, and hence medical therapy was added with oral and intranasal corticosteroid, prednisolone, 25 mg per day for 2 weeks, followed by intranasal mometasone, 2 sprays, containing about 50 microgram of mometasone furoate in each spray, in each nostril twice daily, total daily dose of 400 microgram, for 8 weeks. He was asked to come for follow-up after 2 weeks of treatment. At follow-up, the patient mentioned that he had considerably less headaches and rhinorrhea. This subjective improvement appeared consistent with findings of the anterior rhinoscopy examination, which showed a decrease in polyp sizes. Additionally, there was an alleviation of asthma symptoms as well. At next follow-up 2 months later, the patient did not have any complaints. There was an absence of nasal-oral symptoms, including rhinorrhea, and he had normal breathing and smelling. A case of rhinosinusitis in a patient with Hashimoto's thyroiditis. A middle-aged woman presented to the clinic with nasal symptoms, that is nasal congestion, rhinorrhea and sneezing. About 1 year back, she was diagnosed to have rhinitis, and had been prescribed intranasal antihistamines. However, there was no significant clinical improvement. At that time, a CT scan of the patient had shown features of pansinusitis with bilateral mucosal disease involving both maxillary sinuses and obstructing the osteometal complex bilaterally. She underwent endoscopic sinus surgery for bilateral mucosal disease, following which she was well for more than a year. However, her symptoms then recurred, and at current presentation endoscopy revealed edematous mucosa, obstructing the osteometal complex. Both nasal cavities were filled with thick mucoid discharge. A repeat CT scan showed findings similar to her initial CT scan done about a year back. She was given a trial of medical therapy, and concurrently underwent several routine screening blood tests. Incidentally, investigations revealed presence of normal free thyroxine levels with an elevated TSH level. She was then investigated further, and was found to have low serum cortisol levels, and positive results for thyroid microsomal antibodies and thyroglobulin antibodies. The woman was diagnosed to have Hashimoto's thyroiditis, and was put on hydrocortisone and thyroxine therapy. On follow-up 2 months later, diagnostic endoscopy revealed normal mucosa in both nasal cavities with patent osteobilaterally, together with an absence of thick mucoid discharge. Symptomatically, She was now feeling significantly better, and continued maintenance therapy with intranasal mometasone. A repeat CT scan of the patient showed marked disease resolution. There was only minimal residual disease in the left maxillary sinus. The patient was continued on treatment with thyroxine tablets and intranasal steroids, and was doing well till last follow-up. A case of an adult woman with an atypical cause of upper airway impairment and mouth breathing. A 38-year-old woman presented to the clinic with chronic rhinitis symptoms for about 1 year and suspected allergic rhinitis that was not responding to oral antihistamines used for 2 months. She reported that the nasal symptoms were severe enough to cause upper airway impairment and mouth breathing. The past medical history of the patient was positive for childhood asthma, but currently she appeared to have no asthmatic symptoms. In the clinic, nasal irrigation with saline was done, but it did not provide any relief. A skin test for several airborne allergens was done, but results of the test were negative. A CT scan of the woman showed no evidence of sinusitis. However, there was moderate hypertrophy of the nasal turbinates and nasopharyngeal adenoid tissue, which seemed to explain her persistent upper airway impairment symptoms. This is a case report of adenoid hypertrophy in adults, which depicts several unique aspects relevant to clinical practice. Firstly, adenoid hypertrophy is an atypical cause of nasal congestion in adults, and hence deserves investigation in difficult-to-treat cases. Secondly, while histopathology of adenoid hypertrophy in children shows hyperplasia of the germinal center in adult patients, it shows chronic inflammatory cell infiltrations, indicating long-standing inflammatory process and secondary changes. Therefore, it appears important to consider this diagnosis in atypical causes of upper airway impairment and mouth breathing in adults, and consider appropriate workup and treatment when indicated.